In this study, we explored non-fatal suicide and self-harm events, including both recent and lifetime occurrences, among psychiatric inpatients at a public psychiatric hospital in Saskatchewan, Canada. A key aim was to provide foundational data on this issue following the implementation of a new policy and protocol for the assessment and management of suicide and self-harm at the hospital. Specifically, health data were retrospectively collected from the medical records of 97 civil and 86 forensic patients who had resided in or been admitted to the hospital from April 1st to December 31st, 2021. This included collecting information from admission notes, discharge summaries, a suicide screening questionnaire, a suicide risk assessment guide, and risk management plan, among other clinical forms. Additional factors that were collected from medical records included psychiatric diagnoses, history of childhood trauma, involvement in the criminal justice system, violence, and substance use, as well as measures of hopelessness, social support, impulse control, and coping. Patients' medical records also included information on certain sociodemographic factors and whether they were residing in units dedicated to the treatment of civil or forensic inpatients. In terms of the findings, data revealed that 62% of patients had any record of non-fatal suicide or self-harm events, including 42% with a lifetime history of self-harm and 37% with a lifetime history of suicidal behavior. In addition, 24% of patients had recent self-harm thoughts or behaviors, whereas 31% had recent suicidal thoughts or behaviors. In general, basic group-level comparisons showed that those with a record of suicide or self-harm events were more likely to be younger, female, experience childhood trauma, reside in a custodial hospital unit, have a recent record of hopelessness, helplessness, or depression, and have poor impulse control and coping. Additionally, those with a record of suicide or self-harm were more likely to be diagnosed with neurodevelopmental, depressive, and anxiety disorders, but less likely to be diagnosed with schizophrenia spectrum or other psychotic disorders. When looking at multivariate analyses, it was found that forensic patients were more than twice as likely to have a lifetime history of self-harm. Also, female patients, those with a record of hopelessness, helplessness, or depression, and forensic patients were all more than twice as likely to have a lifetime history of suicidal behavior. Importantly, this study has several strengths and limitations that should be considered. In terms of its strengths, first, we were able to assess suicide and self-harm events for both forensic and civil psychiatric patients. Second, the study filled a gap in terms of epidemiological data on suicide and self-harm among psychiatric inpatients within the Canadian context. And third, the retrospective review of medical records provided unique insight into the historical and recent health information of each patient included in the sample. In terms of its limitations, first, relying solely on medical records had its drawbacks, as the health documents sometimes contain limited, incomplete, or inaccurate information. Second, the tools currently used to assess suicide and self-harm were not validated, nor did they provide critical details on the suicidal and self-harm process. And third, we did not specifically assess the experiences of Indigenous peoples, which is a notable limitation as rates of suicide are higher among Indigenous compared with non-Indigenous people in Canada. It's also important to note that the study was conducted within the time frame that a new policy and protocol for the assessment and management of suicide and self-harm was implemented at the hospital, which may mean that prevalence rates are on the higher end due to greater monitoring and reporting by healthcare personnel. In conclusion, with the high incidence of suicide and self-harm events among psychiatric inpatients, especially forensic patients, this represents a top priority for prevention and treatment in psychiatric settings. However, research to inform prevention and treatment has been scarce, especially within the Canadian context. Although medical records provide valuable epidemiological data, they are unable to present the full picture as it relates to the development and progression of suicide and self-harm, thoughts, and behaviors. All things considered, additional research into suicide and self-harm among psychiatric patients in Canada will lead to more effective strategies for managing these issues in psychiatric settings, especially when informed by theories and practices that acknowledge the complexity and course of suicidality and self-harm.